Hello and welcome back. Today the topic of our discussion is diabetic ketoacidosis. We will be discussing the presenting features, the pathophysiology, the diagnostic criteria, both by American and British guidelines, how we will manage the DKA, and what are the possible complications of DKA, and what is the criteria for resolution of DKA. So let's go ahead and start. First of all, DKA. DKA is a complication of type 1 diabetes, or it can be the first presentation, accounting for 6% of the cases. It can be due to extreme stress, and it can also present in patient with type 2 diabetics. Previously, the mortality was 8%, now it is less than 1% with advanced treatment. Next is the pathophysiology. Pathophysiology is usually by uncontrolled lipolysis, which result in the excess of free fatty acids, which are finally converted to ketone bodies. The most common precipitating factors for DKA are 3 I's. First one is infection, second one is insulin misdose, third one is infarction, myocardial infarction. Then is the diagnostic criteria. We have two better guidelines for diagnosis, the British and the American. First one on the right side is the American guideline, and on the left is British guideline. Glucose should be more than 13, pH less than 7.3, bicarb less than 18, NIN gap more than 10, and ketonemia in American guidelines. While in British, glucose more than 11, pH less than 7.3, bicarb less than 15, ketone more than 3, or urine ketones 2+ on dipstick. Always remember that the presenting features of a patient with DKA will be polyuria, polydipsia. The patient will present to you with infection. The patient can have infarction. The patient can have any kind of infection like cough, like fever. There will be dehydration. So you will estimate that whether the patient is having this precipitation of DKA from which one of the following factors. It can be with UTI, it can be with RTI, it can be with CNS infection as well. Okay, next one is the management. So the key steps in the management are IV fluids. Besides that, we will be giving the potassium replacement as well as insulin infusion, and the final one is bicarbonate. The mainstay is fluid replacement, insulin and potassium. Bicarb we give only in severe cases. The dose of insulin should be 0.1 unit per kg per hour. Once the blood glucose is less than 15 millimole, we start infusion of 5% dextrose. 15 millimole is equal to 250 milligram of glucose. The correction of electrolyte based upon the level of potassium. If the level is between 4.5 to 3.5 to 5.5, then we don't need any correction. If you need to give correction of more than 20 millimole per hour, then you need to do the regular cardiac monitoring. Besides this, we have to stop the rapid acting insulin for the patient, and we have to continue the long acting insulin, and we have to treat the underlying cause as well. If it is infection, we have to start our IV antibiotics as well as the fluids. Then next one is the fluid replacement quantity. Just remember the formula 1, 2, 2, 4, 4, 6. In which each one of them you will give 1 liter of normal saline with potassium chloride. In the first hour you will give only 1 liter of normal saline, but in next 2 to 4, 4, 6 you will give 1 liter of sodium chloride with potassium chloride. Besides this, you will correct other causes as well, for infarction, for infection, other things. Next one is the potassium replacement. It will depend upon the level of potassium. If the potassium less than 3.5, you will ask a specialist. If potassium 3.5 to 5.5, you will give 40 MEq of potassium. If it is more than 5.5, then you will not give any replacement. But always remember, you have to do the cardiac monitoring when you are giving the potassium. Next one is the criteria for resolution of DKA. The pH should be more than 7.3. Blood ketones less than 0.6 and bicarbonate more than 15. So you have to check in the serum, you have to do VBGs, you have to do this urine analysis for ketone bodies, and you have to check the bicarb level as well. Next, if the ketonemia and acidosis do not resolve in 24 hours, you have to inform the specialist or consultant. And once the patient will be vitally stable, he starts eating, then you will stop the insulin infusion and you will convert on subcutaneous insulin. And last one is the complication of DKA. Complications of DKA include gastric stasis, thromboembolism, arrhythmias due to hyperkalemia, iatrogenic hypokalemia, cerebral edema, hypokalemia, hypoglycemia, and hypokalemia also with insulin. And then acute respiratory distress syndrome can be a complication, and acute kidney injury can be a complication. Last one, if the children you are giving the IV fluids, they are vulnerable for cerebral edema. That's why we need 1-to-1 nursing care for the children. Okay, again I want to mention that DK is an emergency situation. We have to manage the patient immediately. Thank you so much for watching.